discussion time in the last. So we'll go to the next presenter. Dr. Rani Balamuralikrishnan is basically going to present to us a revolutionary thought of doing away with betadine and chlorhexidine scrubs. I don't know whether all of us would be shocked by that proposition. Let's hear what she has to say.
Thank you, Dr. Gopal. Good morning to all. The topic is, should we do away with scrubbing? So the background, why we ever thought of this? So during our NABH water surveillance, we had the growth of pseudomonas in the water cultures from all sorts of reservoirs, the tap, the corporation water, and the well water. Meanwhile, nearby hospital and many other hospitals in South India had reported operation theatre sepsis linked to the same organism in the public water supply. And the cultures became negative after hyperchlorination. So when we had the discussion with the microbiologist, she advised that Pseudomonas is a very frequent groundwater contaminant, and she recommended us to use only boiled water in operation theatres and to perform weekly chlorination. Pseudomonas, as you know, is an encapsulated gram-negative aerobic and facultatively anaerobic shaped bacterium, and it poses significant threat to the antibiotic resistance according to the World Health Organization. So the pointing index is towards the public water supply system of Kollam, and there are several studies which show that even the public water supply system as well as the well waters are contaminated. They have extracted coliforms from the water, and as the water potability doesn't include any other organism, they've not cultured that. And you know that E. coli are the commensals of human intestinal tract as well as the Pseudomonas. So the big question is, how safe is your water supply system, and safety of routine scrubbing with potentially contaminated water? Is it as safe as washing your hands in a pond and hoping for the best? What we did was we stopped using water and started using surgical hand rub with 80% ethanol. So there are several evidences supporting rub and don't scrub. The pioneers and advocates of hand rub is Royal College of Surgeons, Edinburgh, UK. And there are several other studies in the net which we can get, which says that surgical hand rub is equivalent as hand scrub. So how we implemented is that this is the procedure. All persons entering the operation theatre should wash their hands with hand wash solution in under RO water and change into OT attire only after washing your hands. Perform rubbing upon reaching the sterile zone, and hand rubbing follows WHO standards. There should be somebody to monitor your hand rub. So this is how we do. We come in the, before changing into the OT attire, we do the hand rub with a hand wash with a disinfectant solution as soap and RO water, and dry your hands as best as possible, and then change into the OT attire so that not a single drop of water fall on your OT dress. And this is the WHO protocol of hand scrubbing, and this is the solution which we use, Sterlomax, that is 80% ethanol. So when you do the hand rubbing, you have to paste the protocol on the steps of WHO steps of hand rubbing on the hand rub area. Then you have to wet your hands fully, as this gets evaporated very fast. You have to do it for 3 minutes and 3 times hand rubbing, and it should be monitored, the quantity, the time, and you see whether the hands are completely dry, and full hand rub coverage was ensured. And in order to avoid contact with water, we have permanently blocked the water tap in the scrub area. So before we started practicing, we did the culture from all the points, that is nail tips, thumbnail tip, and webs of the hand, palmar aspect, and sides of the hand. And the cultures become negative for bacteria as well as fungi. So we have done nearly 4,000 cases in our theatre, and that means 8,000 hands of the surgeon were sterilized using this, and the 8,000 hands of the assistant. So the benefits of hand rub, the observations are, there was no surgical site infection. It is a faster process. There is no risk of gowning with wet hands, no accidental water contact with sterile field, no splash contamination. There was no zinc-associated bacteria, and better skin condition and significant water savings. So when you compare surgical hand rub with surgical hand scrub, we use alcohol-based formulation, while when you do hand scrub, you use chlorhexidine soap or povidone iodine soap. Primary action is rapid killing of transient resident flora. Here, when you scrub, you mechanically remove, and chemical reduction of flora is what is occurring. The time required is 3 minutes. When you scrub, it is 3 to 5 minutes. The water is not required, and skin tolerance is better, less skin irritation. The ease of use, it's very easy, faster, and consistent application. Efficacy, it is either equal or superior to surgical hand scrub when used correctly. The residual activity in alcohol rubs offer longer residual effect, and it is good. The chlorhexidine soaps are good, give more longer activity, but it's low for povidone iodine. And the compliance is high due to speed and convenience, and minimal resources are required. It has a positive impact on the environment, and best used in modern OTs, where high turnover surgeries and water scarce settings. Limitation in soiled hands, you cannot use hand rub, you have to do the hand scrubbing. So how will you improve this? So you have to monitor the quantity, duration, and technique. You have to take random swabs for culture and sensitivity, conduct post-cataract surgery and culture and sensitivity, and see whether the colony count increases after surgery, and perform clinical audits. So in conclusion, the summary points are: surgical hand rub is faster, less irritant, and equally effective as scrub. Surgical hand scrub is useful when hands are visibly soiled, the importance of valuing water as a resource, and increasing global water consumption. So before I conclude, I would like to pay tribute to Ignaz Philipp Semmelweis. He is considered the father of hand sterilization. He has detected that in maternity wards attended by male doctors who did autopsies and then came to the ward for attending patients, had higher incidence of maternal sepsis than in the wards attended by female midwives. So he assumed that some sort of sepsis was contracted from the doctors who attended, from the bodies, the autopsied bodies. So this he invented, this he proposed, and he proposed the technique of sterilizing hands using chlorine. So this he found out many decades before the invention of microorganisms by Louis Pasteur, Robert Koch, and Joseph Lister. Thank you. Thank you for your patient hearing.